Good morning. We're live. Welcome to Psyfeld, where this morning's discussion will focus on the episode, The Marine Biologist. So any observations where we would like to start? We could always talk about George. What did you notice?
So I think there might have been a bit of delusional thoughts going on towards the end because he definitely was not a marine biologist objectively, but then towards the end he was saying things like, in that moment I was a marine biologist, I was able to save a whale, and he really just hyped himself up to actually believe that he was something that he was.
Any other thoughts or observations about that? I mean, clearly it starts out as a lie, right? And what might be the psychiatric parallel to that? If somebody came in and told you something as a practitioner, something that was false or otherwise misleading. Doc, I can't move my left arm.
You mean like a somatic?
Yeah, right. So if intentionally feigned, we're talking about factitious disorder versus the condition formerly known as malingering. It's in an unspecified category now, but I think in clinical circles we still use the term malingering, although it's not a diagnosis per se as of 2013 and the publication of the DSM-5. It probably could still appear on exams. What differentiates factitious from malingering, once you do uncover that the individual is providing misleading information.
Motivation.
Yeah, motivation.
You are doing it for secondary reason, but if it's like the desire
Let's not say secondary gain, let's say external reward, right? At that point where you feel that you've established this differential, the clinician must investigate any external reward, and whether one truly exists or not is irrelevant. If you discover the external reward that you believe is governing or influencing the patient's behavior, we're going to call that malingering. In the absence, it's got to be factitious until proven otherwise, right? So there's a parallel here. I don't think George is necessarily malingering, although there's clear external incentive here. So metaphorical, yes, but not a true diagnosis. So let's talk about his thinking and therefore discuss the role of a delusion here. So first and foremost, what's a delusion?
It's I guess I would describe it as like a fixed belief that is probably not true or isn't true.
Fixed belief that is not bound in reality. Right. Now, again, there could be some truth to it. That's up to the examiner. Unfortunately, in clinical practice, it's not black or white. Shelf exams, I think you're safe. And what differentiates the delusion from obsession? Because both are maladaptive thoughts or deficits in thought content.
Maybe the response to it.
No, I mean, people's behaviors can be very debilitating and functioning can be significantly impaired. Therefore, obsessive compulsive disorder with obsessions. I wouldn't necessarily think severity.
Well, I meant to say like the response of the person to it, maybe.
So, be more specific, yeah.
Yeah, like so a compulsion would be a response to an obsession, because the person finds it distressing, in OCD at least, whereas a delusion would be more like ego syntonic than an obsession.
No, you're kind of circling the drain a little bit. You're almost there. Let me kind of redirect with a clinical scenario, one that you could certainly find on a vignette during your shelf. Patient comes in with a chief complaint of intrusive thoughts. Upon investigation, you believe they have clinically significant obsessions that are significantly impacting their functioning. When you ask about any ritualistic actions, hand washing, counting, etc., the patient denies any current or past compulsions or compulsive behaviors. Single best diagnosis. And the answer is obsessive compulsive disorder, right? In about 10% of cases, individuals with OCD have obsessions only, and that is diagnosable. You do not need to have both components to rule in for obsessive compulsive disorder, right? So one's response is a little tricky. I think if the individual is straightforward and compulsively washing their hands, etc., sure, that might be helpful. However, the absence there really isn't. There's limited negative predictive value here, because 10% of cases are obsessions only. So back to the original question. The answer is insight, and you kind of approach that, but you didn't give me the I word, insight. If an individual demonstrates insight, that strongly supports an obsession over almost a compulsion, over a delusion. Right? Individuals with delusions are not insightful when presented with evidence to the contrary, when given an opportunity to explain how maladaptive and unrealistic their beliefs or thoughts are. They don't, they remain rigid. You said rigid, right? The rigidity comes as part of a definition and qualifying the level of insight.
Does that sort of parallel the difference between, say, somatic symptom disorder and illness anxiety disorder? Because in illness anxiety disorder, they might have some insight into what's going on.
It could, but it's not defining and it's not differentiating.
Okay.
Yeah, it could, but I wouldn't count on that clinically or for exam purposes.
Okay.
Now, this is a little tricky now, but it might come up in an exam, so we've got to discuss this. This is fairly straightforward level of insight, and unfortunately, in clinical practice, it's something that the investigator has to broach. It's not going to be satisfied with a single question. Hey, can you rate your insight on a scale of 0 to 5 for me? It's not going to happen like that. Again, clinical vignette, shelf exam, maybe literally spelled out for you, but clinical practice, a little bit more difficult. And then things in 2013 were made even more difficult in that the American Psychiatric Association adopted a qualifier for obsessive compulsive disorder with no insight. So a patient comes in, they have a maladaptive thought, they have a deficit in thought content, and in the slice of time that is your psychiatric evaluation, they demonstrate no insight. How are you going to figure this out? And the answer really lies in why in the world would the APA task force do this to us when they know that we're sitting for exams, whether it's recertification, whether it's a shelf, making our lives more miserable. Well, I mean, the obvious question to that latter is, it's just patient-centered, right? And this is built on research. What is it? And the idea is just that, we need to appreciate that our interactions with people are slices of time, right? There is a phenomenon called stress-induced psychosis, and one form of psychosis could be a delusion, right? So individuals who may experience stress-induced psychosis may present to you in clinical practice. And individuals with a predisposition to this are those with a history of mental illness, such as obsessive compulsive disorder. So someone has OCD, they have some imbalance of their catecholamine system, largely their serotonin, and now they present because of a psychosocial stressor that's presented last week, and they're in your office now. With a past psychiatric history of OCD, that individual is at risk for presenting with stress-induced psychosis. The single best answer would be OCD with no insight. Of course, when the stressor is alleviated, they are likely to go back to their premorbid baseline of quote unquote only having OCD, if there's such a thing. What that qualifier does, beyond confusing medical students and faculty alike, is it avoids the temptation to misdiagnose and label people and say to a person, because of your past psychiatric history and because of how you're presenting today, not only do I want to address and treat your OCD, but I'm also going to diagnose you with delusional disorder today as well. That's the reason why that qualifier was created. So it wasn't to confuse us, even though it does. And that should be reflected in the vignette, and allow you to choose that single best answer, whether choice A is obsessive compulsive disorder with no insight versus choice B, delusion or delusional disorder. Questions? What else is going on with George here? He might have a stress-induced psychosis after what just happened. And yes, George does have not only a past psychiatric history, but likely active mental illness that has gone untreated. So he's a setup for this new qualifier of whatever it is, and it might be OCD. This is a character that does struggle with intrusive thoughts. But then again, depending on the episode, it could be something else too. George is very rich and dense, academically dense in terms of being such a complex character. Any other thoughts? I think that would be probably the most favorable, quote unquote, single best formulation of what we're describing here in that scene. And in that one time, even him appearing to believe he was was a marine biologist, or even stating as such. Maybe it's a product of stress-induced psychosis. What his actual baseline disorder is certainly topic of another conversation, and one that unfortunately I think would go way beyond our time limit this morning. But I would ask you to consider obsessive compulsive disorder. Anything else with George, whether it's that scene, other scenes? All right, characters other than George Costanza, the marine biologist.
That was the subplot of the Russian writer that's coming in to where we were talking a little bit about. I don't know if it's like an explosive disorder picture, but like yeah, like a
Or
sudden outburst,
disrupts his mood,
or yeah, some
dysregulation,
sort of
one
like
those.
dysregulation of his mood.
Yeah. I think it's very fair to look at an impulse control disorder such as the one you had mentioned. And we may have touched on this before, but it's also reasonable to look back on how this particular group of disorders was previously classified, right? Because prior to 2013, they were published in a chapter titled "The Impulse Control Disorders That Are Not Elsewhere Classified," or NEC. And the mere title of that chapter gave the clinicians their first necessary step in the evaluation, which would be what? Yeah, because if the behavior identified would be within the context of a larger disorder, another disorder, we go with the other disorder. So is this particular character ruling in or suggestive of anything else, and therefore perhaps avoid the diagnosis of impulse control disorder? So is his intermittent and explosive behavior perhaps in the context of another mental illness? I think he may have a personality disorder. You didn't pick up on that? And there are personality disorders that have impulsivity as a diagnostic criteria. And there are two that quickly jump off the page, which are what?
I guess he could be a little narcissistic.
And antisocial personality disorder, right? Failure to plan, impulsivity, or a failure to plan ahead. So I would start with cluster B. And if we feel that he rules in, I would suggest that we could discuss intermittent explosive disorder in the context of a differential when we formulate and provide medical record documentation. But as part of that, I would say that further investigation into a cluster B personality disorder is clinically indicated. And so I use two big words, antisocial and borderline. So we probably should discuss what they are. And then you're going to tell me what the other two cluster B personality disorders are. So first, borderline or antisocial, which one do you want to start with? Antisocial personality. Okay, so.
I guess a pattern of, or I guess something new in terms of like we see a progression sometimes from conduct disorder in pediatrics to antisocial in adults, but these are patients who like seem to have like, I don't know, maybe not no regard, but like they don't hold, if they, I don't know.
Let's say disregard.
Disregard, yeah, okay, disregard for like governing things like laws and things like that. you know, they don't apply to them, so these patients are often like participating for no behavior and stuff like that because of that perspective.
Mhm.
Um,
I think you mentioned it, individuals who meet criteria, and while I don't think you'll ever be asked, all you need is 3 criteria here, and the reason why I bring that up is because it is the lowest threshold of any personality disorder, maybe the lowest threshold of any mental illness. Only 3, which means that, boy, I mean, any of us on any given day could rule in here, right? When you look at the raw number, which is a big reason why the American Psychiatric Association requires a previous diagnosis or a history of conduct disorder. Right? So,
I think it goes beyond disregard for authority. I think it's disregard for like other people in general.
Yeah.
Yeah, like for their rights.
Yeah.
Animals.
yeah, that's true. And even property,
Mhm.
right? A blatant disregard for and violation of others' rights,
Mhm.
right? That's the cardinal feature. And then when you look at the criteria 3+, they just serve as examples of that cardinal feature.
Mhm.
And they're so easy to remember and identify in an exam. But you got to remember that cardinal feature. Right? This is the only condition that is you're not allowed to diagnose in children. Right? Conduct disorder is what you would investigate. Every other personality disorder you can. Now, as a clinician, not sure you would want to, but that's my bias. You can diagnose in children. This is the outlier. An individual with antisocial personality must be 18 years of age or older, and that is published in the DSM. The evidence of conduct must be there prior to the age of 15. Right? That's DSM criteria. I don't know. Is Testatol? I can't pronounce his name. Testatol? I'm not going to try it again. So it's in a differential, as is borderline personality. Now, borderline personality, unfortunately, is one of the few personality disorders that does not have a cardinal feature. That's the unfortunate nature of this. The good news, if there's good news, is that for test-taking purposes, it is one of the more commonly discussed personality disorders. So I don't think it, despite the fact that it does not adhere to a cardinal trait, it should not be that difficult to identify in an exam. Right. So individuals with this condition have significant interpersonal conflict, impulsivity, and definitely struggle with impulse control, and then multiple other criteria for which the diagnosis would be borderline personality disorder. A very, very common question is, and they're probably not going to give you that the individual has borderline personality, but otherwise describe it and ask you what empirical treatment has been shown to actually have positive outcomes in the published literature, and the single best answer would be DBT. Right? So that comes up on exams too. That's dialectical behavioral therapy, or DBT.
And both of those are highly associated with substance use too.
Significant, and that might certainly go along with impulsivity. Matter of fact, there's even a subtype of eating disorder that shows the same exact trend, right? Not that anybody, our author in this episode or anybody else in terms of core characters in the situational comedy has an eating disorder. So I'm not making that statement, but pivoting to the feeding and eating disorders. For anorexia nervosa, there are 2 subtypes. What are they? Restricting, right? Or binge eating and purging, right? The binge eating and purging subtype has significant overlap with cluster B personality traits and a significant comorbidity with the cluster B personality disorders and substance use disorders. Right? Whereas the restrictive type has overlap with cluster C personality traits and cluster C personality disorders. So there we see that breakdown again in terms of impulsivity being clustered with substance use, as well as specific and reliable personality traits. All right, about 20 after, we got 5 minutes. Any other characters you'd like to discuss this morning?
I don't know if it's a bit of a stretch, but I'm just putting it out there for discussion. Like, I think her name was Diane, just being really interested in, I guess, like prestige and George's career and like how people are doing after college or whatever.
Could you give me an example of a scene? Anyone?
Yeah, like when they're at the ATM. And she's like, oh, like, I saw you in the newspaper, like, wow, I can't believe you're doing so great. And like, how's George? Like, he was always such a, low achieving kind of person. And then he's like, well, actually, he's a marine biologist. She's like, oh, no way. Like, so I don't know. I'm not saying she's narcissistic. I'm just like bringing up, that's one trait, right? Like sort of need for admiration or obsession with prestige, things like that.
Yeah, I think for educational purposes, let's say that we identify this observation as being clinically significant for this particular character, resulting in clinically significant distress or impairment. And it's repetitive, it's recurrent. So it isn't something that's going away. And ultimately, because of that, she comes to see you 3 years from now, you're actually in a psychiatry residency. And you're in a clinic and she presents. And the initial assessment allows for information that you've uncovered simply by watching the situational comedy that was assigned. At this point, what are some thoughts that come into your head? Well, and it's a trick question, because at this point, upon first meeting someone, I'm going to ask that you again train your brain to say that it is completely normal and allow the patient to tell you why it's not, right? So they're going to present information that you're going to move off that initial step. And they might do this 100% of the time, but I'm going to ask you to resist the temptation to think of them as abnormal upon them entering the room or you reading the chart. It is always normal until it's not, right? So it was a bit of a trick question. The fact that she then qualifies and tells you, reports that it is resulting in clinically significant distress and impairment allows you to move off that first step. Right? So what else comes to mind now? And just for evaluation purposes, this next step, exactly what we're talking about right now, is your career moving from perhaps as early as your M1 and having this enormous checklist of things that we tell you have to do during a psychiatric evaluation, and pivoting and realizing that you don't have to do all that. Right? So we're teaching you that comprehensive document only to get you to move away from it for the rest of your career. Because when a patient begins to provide information, you're going to go off on tangents and you're going to ask those high yield questions in the course of a normal conversation, which ultimately, even over the hour of the psychiatric interview, may result in you not getting to every box to check that people like me early in your career told you is so important. Right? So what did you see and what direction you're going to go in the first 5 minutes of meeting her?
Based on what Michael had started with, like you're going in the direction of the personality disorder, like somewhere in cluster room.
Okay, so personality disorder, sure. Now, in a personality disorder, let's say you're going down this way, by you going in that direction, you automatically also know that you're exploring what? Because you can't diagnose a personality disorder without first investigating and ruling out blank. Basically, what you told me by saying personality disorder, and you're not wrong, is a 4-in-1. That is, there's personality disorder, but there are 3 other things you automatically have to consider when evaluating for a personality disorder. The American Psychiatric Association states that in investigating, evaluating for, and diagnosing a personality disorder, the clinician must also investigate the direct and physiologic effect of a substance, and whether the behavior is otherwise attributable to an underlying medical condition, or if those maladaptive personality traits that you have identified that we are discussing in the context of this patient and that scene is not otherwise due to another mental disorder. So you've taken a necessary first step, but you still have a very broad differential that's going to govern your questions that will comprise the next hour of your psychiatric interview. If we could say that there is no evidence in this particular episode of a use of a substance or an underlying medical condition, and further workup reveals that our initial assessment there is in fact correct, what other mental disorders are we going to consider And the good news is that in the psych eval, you're gonna screen for all of them because it's the routine cycle. That's where the stuff that Toby had taught you to repeatedly do over and over again comes in. Why a depressive disorder here? Let me state it more closed-ended. Why a depressive disorder here? Or why would you think this type of thinking might pose risk for a depressive disorder that you know you're gonna have to evaluate for, and something, at least in the depressive anxiety cluster?
For me, I think that that comment kind of points to some unhappiness or negative thoughts about herself.
Yeah, when people need others to validate who they are, and when they kind of pay attention to the success of others as some type of a barometer, that's a concern. Yeah. Now, again, completely normal, but in the proper context, this is the way a psychiatrist, psychologist may actually think about going and asking further questions to make sure that there isn't a primary mood disorder, like depressive disorder, or an anxiety disorder that is resulting in her doing what she does and saying what she does, right? This idea that this scene may be indicative of what is referred to as an external locus of control. And therefore, the individual does not feel an internal locus, and that she has control. In this case, she has control over her situation, and therefore her career, her life, etc. Right, so I think that's something that the initial interview might actually consider. All right, we're going to stop here. We're right at the bottom of the hour. We're going to log right back on at 8:30 on our other link, and join the interns there on the other side. Thank you.